It is essential to gather comprehensive information related to shoulder pain. Thus, history taking requires a prompt approach to understand the patient's condition fully. Here is a structured approach you can follow. We look at type of pain, either it is localized or diffuse. Localized pain is mainly felt at acromioclavicular joint and bicipital area. Onset of pain can be acute or insidious. Acute occurs due to dislocation, subluxation, or rotator cuff tear, while insidious occurs in rotator cuff tendinopathy. Position of the shoulder at the time of injury also matters. Suppose if a person falls with arm wrenched backward, it suggests anterior dislocation. A fall onto the point of the shoulder can cause acromioclavicular joint injury. Severity of the pain is usually assessed through visual analog scale. Aggravating and easing factors are noticed along with effect of pain on activities of daily living. You can also ask the patient if he experiences night pain. It is very common in rotator cuff dysfunction and adhesive capsulitis. Sensory symptoms like numbness and tingling is also checked. Also ask the patient if he experiences catching and locking during certain movements. Past and present problems and predisposing factors are also noted in medical history. To easily understand shoulder examination, let's divide it into easy steps. During observation, the patient is observed from the front and from behind. So a physiotherapist can look for muscle wasting, asymmetry of shoulder height, scapular position and muscle bulk, etc. Patient is asked to perform following movements: flexion or arm elevation, external rotation with elbows at side and at 90 degrees of abduction, internal rotation, horizontal flexion. Look for scapular dyskinesis during arm elevation, which means patient has weak scapular control. Acromioclavicular joint injury causes pain during horizontal flexion. Same movements are performed passively to examine and feel. Physiotherapists should also palpate following structures: acromioclavicular joint, rotator cuff tendon, and bicipital groove. It is important to rule out the structures involved and cause of pain before confirming it through diagnostic imaging. We start with simple drop arm test. It confirms that the patient is either having impingement or rotator cuff tear, mainly of supraspinatus. To confirm impingement, Nair and Hawkin-Kennedy test is performed. For rotator cuff tear, empty can test, lift-off test, belly press test, and hornblower sign is performed. To assess scapular corrective maneuver, scapular assistance test and scapular retraction test is performed. To assess instability, load and shift test, apprehension and relocation test is used. For acromioclavicular joint, modified O'Brien test is used. To check functional capacity of shoulder, Apley scratch test is performed. To diagnose slap lesion, Yergeson and O'Brien test is used. Diagnostic imaging helps in efficient management of the patient with shoulder pain. X-ray is conducted for calcific tendinopathy, glenohumeral joint arthritis, impingement, proximal humeral head migration seen in severe rotator cuff dysfunction, and fractures. Ultrasound helps in the evaluation of tendon swelling, thickening of bursa, abnormal fluid collection, calcific tendinopathy, and rotator cuff tear. MRI is used to detect rotator cuff tear. Arthroscopy of the glenohumeral joint cavity provides evidence of Pankard lesion or a slap lesion. It shows presence of a Hill-Sachs lesion. Arthroscopy of the subacromial space allows for the assessment of bursitis, spur formation, and full thickness rotator cuff tear.